A very good evening to the August gathering. A good day is just being able to breathe. So take a deep breath for yet another exhilarating session on COPD, recent advances and its management. For the session, I would like to invite our chairpersons to grace the stage. Dr. Ashish Tandon sir, a renowned chest physician and director of Haridaya Super Speciality Hospital. Dr. Abid Saeed sir, chest physician at Tej Bahadur Sapru Hospital, Prayagraj. Please join us on stage. And Dr. Dayanand Kesarwani sir, chest physician at Colvin Hospital, Prayagraj. I would now invite our distinguished speaker, Dr. UC Ojha sir, to grace the dais. I would request one of our chairpersons to please introduce the speaker.
Thankful to the AMA for inviting me to the academic feast, especially Dr. Ashutosh Gupta. We are here to introduce Dr. UC Ojha sir. He has been working with the Employees State Insurance Corporation and has been working as a professor of pulmonary medicine in ESI, PGI and ESI Hospital, Badarpur. Internal and external examiner for DM and DNB students, Associate Fellow of Industrial Health, former Director, Institute of Occupational Health and Environmental Research, ESI Hospital, Basayatpur. And he has many awards to his credit and has been the participant as guest faculty in various National College of and Indian Chess Society organized national conferences. So over to Dr. UC Ojha sir.
At the outset, I'm thankful to Chairperson for allowing me. Thanks to Allahabad Medical Association and my friend Dr. Ashutosh Gupta, who has given me this opportunity, but this challenging opportunity. The reason being is my predecessor speakers were all my teachers, and I've learned a number of things from them. So it's like Sachin Tendulkar and Dravid. And after that, you are asking somebody to play. It's really a tough task. But let's see. So, see, breathing is something, you must have heard, the person has taken the last breath. Sir ka आशीर्वाद है sir. Whatever I am here because of Professor J. Suri. So it's a time for the world to take COPD seriously. The reason being is, everybody, whosoever goes from this Mother Earth, says he has taken the last breath. And how breath is important. See, I'm not going to talk about details in terms of informations. Fine. Internet is full of information, Google is full of information, AI is full of information, which is wisdom of a good number of scientists. So what I'm going to give you some concept which I have derived for last 35 years of my experience in occupational respiratory medicine, which directly deals with obstructive airway disease and interstitial lung disease. But now my talk is on COPD, recent advances, so I'll dwell upon that only. So, as you see, at the beginning, as Professor Surya sir has said, if there is damage something early, it declines early as well. So one has to be very careful, because these trends do matter in life, in obstructive airway disease as well. So disease is near its beginning. See, now few definitions to recapitulate. What is early COPD? It is disease, it is near its beginning. Young, we say COPD in young patients when it is from 20 and 50 years of age. Pre-COPD is, there is no airflow limitation in terms of FEV1 upon FVC, which is more than 0.7 as per definitions. Disease activity is when there is some biological terms that relates to the level of activation of pathobiological process that causes the disease. But yes, there is no biomarkers for it. There are n number of risk factors. But to understand this, we have to understand the comorbidities along with it, because just airway obstruction along with other disorders can damage the whole body, the whole system. It's not a disease. COPD is not a disease per se of airway. It involves every part of the body, as our obstructive sleep apnea is. So we should not do a compartmentalized management of a disease. Fine. Here is a comorbidome. Comorbidome is if somebody has COPD as per the definitions of Gold, then there are n number of other diseases which can cause the ultimate. And you cannot ignore anything, and everything is dependent on each of them. Like even this disorder which I am going to talk about is, it causes hypoxemia, releases cytokines, different ROS, that is the active oxygen species, different proteases, resulting into all this. Heart failure, CVD and all. So, friends, COPD is not COPD per se, just not an airway obstruction. If the channel is blocked, you are from Prayagraj. You have seen channel was blocked in the recent event which has happened, and how troublesome it was for the local people. Fine. Similarly, if the airway is blocked, the whole body is affected by this way or that way. And on top of it, what we used to say, the lung parenchyma is, what my previous teaching was, lung parenchyma has no bacteria, no microbiome. But there are microbiomes which has been proved genetically, and they get changed by virtue of usage of different drugs. And on top of it, there is an epistemic injustice. Epistemic injustice is when somebody is getting affected and he is not asked what you are suffering from and what the disease should be treated and how it is to be treated. And that's why in the recent monograph of COPD, which ERS has recently published, they talk about, they have included the first chapter in that, where the patient's purview, what patients think of the disease, what patients perceive, what patient wants from us, they have described beautifully in that. And let's change the gear and think. If somebody comes to you and says, I have a fever, what do you say? This patient has a fever. This patient has a COPD. This patient has an asthma. But if you see the changing concept recently published, it says it is done to people. Patient was not born with that. Here is a paradigm shift, an argument worth visiting or revisiting. Like COPD is because of the topic which is ignored for good number of years. And I'm sorry, this is irritating. So you see, if you ask a current job of somebody, What are the exposures at home? That is microenvironment, temporal relationship with their symptoms, and the sentinel events. Then a totally ignored area of environmental illness comes into play. And COPD is a result of one of these. And the thing which I was talking about, the first chapter of monograph, they say fear of possible breathlessness results into dyspnea, causes anxiety and causes panic attack. This is what patient needs. And this is what patient says. Give me this care. The reason is it involves all the airways and all, and it causes vicarious dyspnea in the family as well. What is vicarious dyspnea? This is observing dyspnea in others. It elicits a mild to moderate dyspnea, negative effect, and increases brain responses in the absence of respiratory changes in the observer. Mind you, friends, not in the patient. Patient's family is also suffering. And this causes increased suffering in family and medical caregiver. Even you and me are suffering because of that. So this vicarious dyspnea is as bad as any pain. And that's why they say, treat the lungs, fool the brain, and appease the mind. And this is what the holistic care is and what it should be. So, dyspnea has long been compared to pain. Neurophysiological similarities with it, yet in many ways, dyspnea is probably worse than pain. Acute dyspnea goes hand in hand with fear, the fear of dying, which is not systematically the case with pain. Fine. So this is worse than pain, friends. There are different tests. You all know, I'll not dwell upon this. This is for postgraduates that look for oscillometry, go for 5 Hertz. For the total airway resistance, look for 20 Hertz. Large airways, minus them, get small airways. And small airways is the first which gets involved. But yes, we all are doing spirometry, fine. But whether our spirometry is doing a right job or not, for that a recently published article suggests a very nice, beautiful thing. Says, look for FIVC, that is forced inspiratory vital capacity minus forced vital capacity. It must be less than 100 ml. If it is not that, then your patient has not performed the PFT right. And if this PFT is not right, then it is not going to give you a good trend. Number one. Number two, whenever you are eliciting this, I'll add to it FIVC, look for forced inspiratory volume. Whether it is 30, it is 60 or 80, because this is going to play a long role while you are going to prescribe inhalers. You are going to prescribe the DPIs, because for DPI to get properly activated and deposited in your lungs, it has to have certain inspiratory flow rate. And practically nobody, because peak inspiratory flow meter is not available in India practically. I was searching in Amazon or other things, PIFR meter is not available. Whereas the recommendations are now coming up. They say, look for PIFR, demonstrate to the patient, look, now your PIFR is this, you have to generate this much force while I'm prescribing those inhalers, which my morning session people have described. If the adequate PIFR is not being generated, the volume of the drug is not going to get deposited in the desired airway. So to define it, COPD is a chronic disease. It has certain abnormalities and it causes certain effect. Fine, and you have to address everything. And this is what our recent report says. But yes, COPD gene study says nothing. You have to think beyond that, which is going to be published very soon, in coming years. What they say is, look for exposure, look for symptoms, look for spirometry, look for CT imaging. And if all the 4 are positive, then it is definite COPD. If 3 is positive, it has a different meaning. If 2 is positive, it is pre-COPD and all. So pretty soon, friends, you are going to have look all these 4 domains in near future. So COPD is not merely cough with expectoration. It involves the whole body, and it has these domains as well to look into. So it starts from the conception till the death. It has different domains one has to look into, and they all affect it. So this is all you know. I'll not touch upon that. But yes, we have to reduce the symptoms, as I explained earlier, because these symptoms not only affects the patient, it affects the caregiver, it affects the physician concerned also. Fine. And we have to reduce the risk so that this further cannot damage or increase the symptoms. Management, you all know, basic inhalers and all. I'll see if we classify them group A, B, E and all based on MRC. And it's simple. Guidelines are very clear in that, so there is nothing new in it, except for if the patient is in group A, that is 0 to 1 moderate exacerbations, MRC 0 to 1. 0 to 1 means patient is able to do his work regularly, and just simple bronchodilator suffices. But if MRC is more than 2 means if he is unable to work with a space with a similar person, or more than that means he cannot work more than 100 yards, you have to add a LAMA along with a bronchodilator. LAMA combination you have to give. But if he requires admission and all, then you have to add LAMA and consider ICS if blood eosinophil is more than 300. Here is a catch. We tend to prescribe 3 drugs to every patient. Please be careful, because this is going to damage the microbiome of the body, of the airways, and they can cause further different this thing, because dysbiosis in the airway leads to certain damage which is difficult to treat in this thing. So yeah, this is what I was talking about. If you are giving meter dose inhalers, the inspiratory flow rate should be 30 to 60 ml. 30 to 60 liters, sorry. So how can you say he's breathing 30 or 60 unless otherwise you train him? Just telling them inhale deeply will not serve the purpose. My inhalation may be different than XYZ's person's inhalation. So you have to demonstrate, document it, yes, now he's fit. Because unless otherwise the techniques are okay, the drugs are not going to be that effective. Similarly for DPIs, it should be more than 60 if there is if it is low to minimum resistance, and if a high resistance DPIs, you have to give flow rate more than 30. Here there is by look wise there is a discrepancy, but it's not that. If a high resistant DPIs you add more flow rates, it will not cause that much disintegration to the drugs and cause clumping of the drug in the machine itself. And if a patient is a normal tidal breather, give nebulizer. So the rule is here. If there is a cognitive function, patient is okay in his cognition. If there is a manual dexterity, measure PIFR, peak inspiratory flow rate. Based on that, decide. And if there is no dexterity, if he is unable to follow your instructions, go for nebulizer. So in future, they are going to talk about high fiber diets, probiotics, fecal transplantation, phage therapy. Somebody has asked in IID regarding phage therapy or gene therapy. Phage therapy is going to come pretty soon for resistant bugs. Use of CT, we all know, they can be used to diagnose early for centrilobular nodules. Look for centrilobular nodules, look for air trapping, look for expiratory films, and diagnose. As COPD gene study says, you have to look for CT to early diagnose the cases. Vaccination, they all are essential part. Now October is coming, viral vaccine is due for those patients who need it. Similarly, DTaP, zoster, RSV, they all are going to be this thing, roll now. So, but most important is this biomarker, which was a good biomarker for asthma. Now it has come a great way in COPD because this, along with this, increases type 2 inflammation and a distinct pulmonary microbiome. So, blood eosinophil counts are predictive biomarker of the corticosteroid response and facilitate patient selection for biological treatments. Not only steroids, but good number of biologics have come and they can be of some use. But you have to be very choosy. It's not an umbrella prescription. You have to be choosy, you have to be specific. Like if there is a high eosinophil count, there is a high variability in terms of blood eosinophil count, in terms of small airway damage, in terms of central airway variability. But if there is low eosinophil counts, the variabilities are less. So here we can affect more with biologics and steroids. Otherwise, our simple treatment should be lama along with avoidance. That is most important. And avoidance means there is one thing which has been ignored for ages together since BC, and that is environment and microenvironment where people live. Roflumilast has come recently, and this can be used because it causes a significant reduction in eosinophil counts in bronchial biopsy. So here is a drug which is of some use, but yes, biomarker is eosinophil. Benraliz has come. It affects IL-5, again a product of BEC, blood eosinophil count. But it should be more than 220 cells per, then there are experiences that it helps. Similarly, mepolizumab has come. They all are useful. Mind you, please, it should not be used left, right, and center. You have to be very choosy, very definitive in treatment. And you have to follow the guidelines. Now comes my favorite topic, and that is pulmonary microbiome. In stable state, it is different than in healthy individuals. So several dysregulated mechanisms of COPD, including reduced mucociliary clearance and impaired host immune defense, creates a favorable environment for bacterial colonization. Microorganisms, mostly probably protobacteria, including the species that is H. influenzae and Moraxella catalyst, they are there. Fine. And these species, along with strep pneumoniae, are the most commonly isolated bacteria from airway samples of COPD patients in stable state and during exacerbations. But if you damage, then one bacteria gets upper hand than the other, and that is the term which they say dysbiosis. Dysbiosis means an area which is colonized by good number of people, they balance each other. And if that balance is being disturbed, then the bacteria which is dominant will take over and causes more damage and causes recurrent infections, pneumonias. They are talking in terms of plasma fibrinogen, but it is not come into picture. Pheno, yes, again indirect representative of airway eosinophil. So see, now their concept of organoids are coming up for a COPD and all. What they say is there are 4 groups: bronchosphere, bronchiolar organoids, bronchoalveolar organoids, alveolosphere. They are going to be they are trying to work on their regeneration to protect us. But it's a future, still in the experimental stage. Current pharmacotherapy, I have covered up. These are all in guidelines. I'll not touch upon that. What I'll prefer is, yes, this is something which is very much ignored for COPD patients. And this is to be given upper hand for every single COPD patients. Even sit to stand exercise from the chair. 5 times, 1 set, 2 set, 3 sets. Sit to stand from the chair itself is going to be good, give them good booster. So rehab is to be taken good care of, because this is an area which is totally untouched in every part of country, except for big centers where there is a special units. This topic is this is something which is untouched, and any physician can do it. You don't need any good gadgets for that. If you have seen old movies, those prisoners of war, they used to do exercise in the small chambers. If they can perform work over there, we as a physician can train our patients. Yes, can sit stand from the chair itself. 10, 20, 1 set, 2 to 3 sets, fair enough for the lower limb, because it's the lower limb muscles which gives away first, and patients in a vicious cycle, and that vicious cycle ends in bedridden state. And mind you, friends, as I talked about, bedridden means vicarious responsibility for the patient's family doctors. So there are different groups. I will not touch upon that. Yeah, I'm leaving these slides for postgraduates who are there. They can. So my last slide would be, I'll leave with this unanswered areas. So take home message I'll suggest is, we have to diagnose early. Avoidance of exposure is the key. We all have to rethink. Avoidance of exposure means anything which comes in 8 inches from your nose, that is your breathing zone. Anything which comes there is going to go to your airways, is going to go to your alveoli, depending on the particle size. Smoking cessation has a big role. Appropriate use of inhalation devices, optimal use of biological or newer drugs, optimal use of oxygen and IV, comorbidity management, record keeping. We are very poor in record keeping. We have to upgrade ourselves here. We have to upgrade ourselves here. We have to upgrade, where is the exercise? Comorbidity management and exercises. Thank you very much for giving me this time. Thank you very much.
Thank you for the excellent presentation on the COPD newer concepts and the newer modalities of treatment. Any questions from the floor?
It's a very nice presentation by Dr. Sir. In the COPD management, just I want to one thing that a lot of patients come with comorbid condition, COPD, like sleep disorder, and that's all. Any medication can be provided by treating the patient of COPD with sleep disorder.
So sleep disorder is a very big term. It's like, see, what kind of sleep disorder is he? Is he has insomnia?
Is there any obstructive sleep disorder?
For that, sir has suggested. We have to study. We have to do a sleep study That's why I said in last but one slide. Here it is. Because paucity of time, I have not covered this because there are overlaps. We have to look into that also. But it's like, compiling Ramayana in 4 sentences is very difficult. Sir, your voice is not coming up. Sorry.
Is there any medicine? Is there any medicine to just cover the COPD as well as the sleep disorder like ultra lama or ultra lava? No.
Sleep is to be studied thoroughly, and sleep is to be studied holistically. We have to diagnose it. We should not take a tidbit of this, tidbit of that. We have to study, and Sir is sitting there. He is doing sleep here, I know. So he must be doing full night study, he must be doing analyzing the data, then only he is coming out with the things.
There the concept of traits has been given, and in that trait we have to identify
Yes.
pulmonary and the extrapulmonary trait.
Yes.
This comes under the trait of the COPD, which
They are
covers
phenotypes.
both COPD
Phenotypes.
plus OSA. So,
They are phenotypes, that's why I say
yes.
overlap.
Yeah.
It's there. Overlaps. They have to listen. So in 25 minutes, it was injustice from my side to cover sleep along with when my guru has already talked about.
Can I ask you one question?
Yeah.
We talk a lot of eosinophil count,
Yes.
more than 300, and
Yes.
SITT, single inhaler triple therapy,
Yes.
which is in group E. And do you have anything which suggests that Pheno can be a useful tool to identify those patients? Can it be applied to the COPD?
One, Pheno is is a very handy tool. If it is available, we can try. There is no harm. But as far as data is concerned, you have to look for blood eosinophil counts. Because Pheno has not replaced for that in COPD as of today. For asthma, yes, but for COPD, we have to look for blood eosinophil count, and then. Thank you.
Thank you, sir. Thank you, chairpersons.
Thank you, sir. Thank you.
Thank you.
For a very lucid presentation. Thanks, sir. I will request our speaker and our chairperson to move downstairs. Thank you.
I would now request our President AMA, Dr. J.V. Rai sir, Dr. Ashok Mishra sir, President-elect, and Honorary Secretary AMA, Dr. Ashutosh Gupta sir, to felicitate our distinguished speakers and chairpersons.
Okay.